Now, many of us is probably either remote or on the way go to Chicago for the AAN meeting. But it's really my great pleasure to introduce Dr. Amr Burhan as our guest speaker, grand round speaker today. And Dr. Burhan was born in Syria and raised there till 6 years old. And then in the next many years, he actually traveled to Lebanon and Morocco and Pakistan. Went to his medical education in Iraq in the College of Baghdad University. And then he graduated in 1993. You remember that part of history, the first Iraq war happened. So he left the Iraq, the war-torn country, and joined his family in Canada. There, he had to do this medical exam of both United States and Canada board exam. And he began his neuroscience research at the Montreal Neurological Institution and won the prestigious of Jenny Tammins Costello Fellowship in the basic neuroscience research. This experience cemented his commitment and passion for neuroscience in general and neuropsychiatrists in particular. So after his psychiatry residence training at the University of Rochester, United States, and the fellowship in Western University in London, Ontario, he began an academic career with a two focus. One is the neurocognitive disorder, and another is interventional psychiatry for treatment-resistant mental illness. He's currently certified, board certified in behavior neurology and psychiatry and geriatric psychiatry. Until 2020, before pandemic, he was the physician-in-chief at Ontario Shores Center for Mental Health Science, and also chair of the Division of Geriatric Psychiatry at School of Medicine Dentistry of Western University. He's currently the endowed research chair for applied mental health research at the Toronto University and Ontario Shore Center for Mental Health Science. He had more than 100 full publications and leading many clinical trials. I'm actually so much looking forward to hear his wisdom on the resilience, the cognitive resilience. His journey represents many resilience, like many of us travel to here to meet. Particularly his expertise and the perspective from international perspective, how can improve our care for people who suffer cognitive decline in aging process. Without further ado, the floor is all yours, Dr.
Thank you so much. Thank you so much for the invitation, for generosity. We had a very nice get-together yesterday with the group working in this field. And thank you all for being here. I think, as you said, resiliency is really all of us. We have to navigate so many challenges. Obviously, the resiliency comes from learning that you have to move where you can have an opportunity to work with people and connect with people, and it enriches who you are and enriches your ability to help others as well. So I don't like boundaries. I travel, I connect with people, and this is an opportunity for me to connect with your group here to talk about really cognitive neuropsychiatry in seniors. And really, I'm not only talking about those who are 65 and above. We age every day, and aging midlife and older adults do deal with issues that affect their cognitive resiliency. And this is one way to kind of think about this in a framework. So this is not a scientific paper. It's really looking at the aspects that we can help with as we navigate through aging. Just trying to advance this here. It looks like the slides are just not moving, but I'll try with this one.
Yeah, turn it on.
Okay.
There you go.
Oh, go the other way. So I'm going to look at the neuropsychiatric and behavioral manifestation across the cognitive spectrum in older adults, how to evaluate pharmacological brain stimulation interventions that support cognitive resiliency, and advocate for an integrated technology-enabled framework to help us kind of help people building those resiliencies. So I have some declarations. Like all of us, work with a lot of entities, both peer-funded and industry. We go where the interventions are, and I have collaborated with a lot of people at different levels. Now, none of this is being promoted here, so you'll see that it's really looking at the science of things more than anything else. So I come from Ontario Shore Centre. Is literally on the Strait of Hormuz. No, sorry, it's on the Lake Ontario. More friendly waters, I hope. So we're across from upstate New York. Actually, I trained across the lake in Rochester, New York. So Toronto was north. Now Rochester is south. And we have a facility that serves people with. So I thought that our facility is a beautiful one. I come to Virginia and Charlottesville, and so you guys have a beautiful place here and such a nice, charming town that maintains the history. And so hopefully I'll be able to share with you my learnings over the years. So I don't need to convince you that cognitive disorders and dementia is a growing problem, going to continue to grow. And these are some of the numbers that were published by the Alzheimer's Disease International. Actually, they just finished their meeting in Lyon, France. Some of my colleagues are there. So dementia is, it's not one thing. It's an umbrella term. Alzheimer's disease is the big share, about close to 75%. But the vascular story is there, and we know that there's Lewy body and Parkinson's disease dementia that takes part of that as well, and the frontotemporal dementia and the whole spectrum of that represent probably 10%. I'm going to focus a little bit more on Alzheimer's disease. It's actually the illness that I believe it's, the epidemiology of it is so strong, and it's going to affect all of us some way or the other through friends and relatives and families and ourselves too. So the first case of Alzheimer's disease, as some of you know, that was described in only a 51-year-old person. So this is Augusta Dieter, who was admitted. And Dr. Alois Alzheimer described her as somebody with memory issues, language issues, but also psychological symptoms. So did have hallucinations. When she died, and Dr. Alzheimer did look at her brain. He was a neuropathologist, did the silver staining, and described what we currently just started targeting therapeutically. So this is over 100 years ago. The amyloid plaques were described, and only the last few years we're able to actually do something about it through the amyloid trials that are getting a lot of attention these days. But we all know that the trajectory of this illness starts quite early on. So before anything else happened, you could detect amyloid changes. So if you follow people over time and you either draw their CSF or do a PET scan, you may see amyloid many, many years before any changes to even the brain volume or clinical symptoms. So clinical symptoms don't show up till much later. And tau comes next, indicating that the neurons are now being injured. Then, of course, the manifestation of neuronal loss shows up in structural images that when you look at an MRI. And then cognitive symptoms show up. So we really have a long journey that we can look for opportunities to intervene and find a way to help people. This is just getting closer to what it looks like. As you know, the amyloid beta, it's the longer molecule that tend to be sticky and accumulate in neurofibrils and trigger a whole cascade of events that we still need to understand, because while removing amyloid is the more obvious therapeutic target, it's not the full story, because we know that people don't reverse the illness by removing amyloid. So you really have to think about the neuroinflammatory changes, the neurotoxic changes. So, and then, of course, the tau tangles are things that accumulate inside the neurons, indicating that now those neurons are no longer able to survive. And there's, of course, hypotheses in terms of what happens. One of it include mitochondrial damage, where the energy mechanism inside the cell get affected, and the neurons gradually, start the programmed cell death, the apoptosis. So what we know today is that we can see amyloid and we can remove amyloid. And then there's a lot of work being done on targeting tau. But so far, the only one that have shown any clinical value is removing amyloid. And we have the two drugs approved in the US, is the lecanemab and donanemab are two drugs that remove amyloid successfully. And they show some clinical value compared to placebo. Now, one thing that you start seeing more and more of is detecting the amyloid as early as possible, and how significant that is, how useful it is. So this is kind of almost the plasma clock for Alzheimer. So one of the markers that is getting quite popular is the phosphorylated tau 217, and that is not a reflection of tau in the brain, actually a reflection of amyloid, which is kind of interesting. So when you check, you can get about 87% predictive power to say that there's amyloid in the brain. And when you take people to a PET scanner, you can see that amyloid. So this is leveraging the ADNI study, the Alzheimer's Disease Neuro Initiative, that actually gave us thousands and thousands of people, and looking at those biomarkers helped us validating that maybe a blood test is possible. Now, the meaning of that, is it really going to translate to Alzheimer's disease? That's still debatable, because some people probably have amyloid and do not develop Alzheimer's disease, but this is at least a marker. So one possibility is that if you detect amyloid through this plasma test at age 60, you have about 20 years likely, so in 20 years, a person may develop the illness. So you have an opportunity to actually do something about it much earlier than we were doing before, which is waiting for subjective cognitive impairment, mild cognitive impairment, and actually Alzheimer's disease. And we're also learning from trials that the earlier you start, the better, because those who have mild dementia, they don't do as well as mild cognitive impairment. And even within the mild cognitive impairment, the earlier you detect it, the better. And now we have a lot of prevention studies are happening. So lecanemab is in prevention, donanemab is in prevention, trontinemab is, so all these maps are now being offered to people who have the risk of Alzheimer's disease and have amyloid in their plasma or in their brain. So the framework that I follow, that we have a lot of opportunities to foster resiliency, because we deal with, so in psychiatry, obviously in geriatric psychiatry, we deal with depression, and depression in middle and old age is a predictor of Alzheimer's disease, and then finding a way to modify that. So before even people developing any other symptoms of cognitive disorder, they may be just developing depression for the first time, or a worsening of a previous depression. And I find that this is a good opportunity to make a difference. And then there's a whole construct of mild behavioral impairment. So this is a change. We used to call it personality change. Or they say, well, yeah, a person may have a personality change, and then you wait to see if this is going to translate into a... so there's actually work that have been done to articulate a very good model to detect those behavioral changes. And I'll share with you some of the work. This is from Dr. Zainur Ismail. He's in the University of Calgary. And then, of course, it's what we know in the clinic today, in the memory clinics, like mild cognitive impairment and Alzheimer's disease, the way we diagnose it. So there's a journey that we can tackle. So I thought about, like in what way we can provide intervention. Well, there's the lifestyle, and managing risk factors, including depression, is something that we all have to be expert in. But also thinking about, like, this is not the end of my role. So if I'm a psychiatrist treating somebody in their 50s with depression, I need to keep in mind the possibility of this being either a risk for Alzheimer's disease or even an early manifestation of it. Without having that integrated model and that ongoing collaboration, we're always going to do our bit and send the person away, and then the family will say, but they still have this memory problem. They're not depressed anymore. And then now you have to get to a new referral and see a new person. Well, I think we need to be a little bit more integrated and think about this as a spectrum that will allow us to. Now, if the person recover from depression and have nothing left behind, fine, maybe they no longer have that risk. But it's not satisfying to me to just stop at the end of my treating of depression. And that the mild behavioral impairment and depression as a prodrome of cognitive disorder is definitely a different thing, because a person could get depressed in their 20s and have another episode in their 50s. That's different from somebody who, for the first time, they start having this sense of like, I'm not managing well. I'm you know, flustered with anything. This is a new change for them, and that could be the prodrome. And we are now aware that about within 5 years of Alzheimer's disease, you could have a depressive anxiety episode that is new to you. And those are opportunities for us to detect people earlier. Then, of course, the cognitive symptoms of somebody with MCI, mild cognitive impairment, Alzheimer, you always have to think about them cognitively, behaviorally, and functionally. So it's not, you know, one thing. It's making sure that the memory is impaired, but how does it affect function? Is there any anxiety and depression? So in terms of the scope of work that I've been involved in, so I do work in cognitive resiliency using multimodal interventions that include cognitive training and exercise, but also brain stimulation. We have, you know, late life depression going beyond just medication, so TMS and magnetic stimulation. Behavioral aspect of dementia, we've collaborated with, you know, Carol Manning, who's sitting here, as part of studies that we worked on. And then improving measurements and finding a way to leverage some of the predictive modeling and artificial intelligence that may give us a little bit more of a stratification of the risk, you know, who's going to develop these illnesses. So some of you have seen this. It's definitely Jill Livingston, who spoke to us actually 2 weeks ago about this. So this is actually now a living thing. Like every country now is articulating their own. So while this was published, became famous, we have a Canadian version of this that shows a little bit of a different risk. So some people ask me, why is sleep is not there? Well, some jurisdictions showed sleep as a problem. So I think we're learning more and more to identify more and more of risk factors. So for me, like early education, early enrichment, we've seen it from the religious order study, that those who have earlier education that is quite rich, they tend to protect themselves longer. So that's but then in the midlife, like you have so many factors, including hearing problems. So this is one of those things that was a complete surprise to us, is how robust was hearing impairment and the response to correcting hearing in protecting people from dementia, right? So it's something that we have to think about. So now I need to think and collaborate with audiology and ENT, because they're a core part of what we do. Then, of course, you think about, you know, all the modifiable factors. My colleagues in medicine would know: high blood pressure, high cholesterol, depression, as you can see, has a contribution, traumatic brain injury, smoking, excessive alcohol, and obesity. Now, as you go to later life, you start seeing things that are interesting from even societal perspective, like social isolation, loneliness, visual impairment. Those are things that we don't think about clinically but they're so influential on people's survival, not only in cognitive way. Loneliness predict worse outcomes from heart disease, from stroke. So I don't think we can afford sticking to only one thing we know. Like we have to think about, so at a population level, we need to be prepared to provide people the opportunity to you know, age in a resilient way, and of course, modify what we can modify. This is, you know, that was more of a prevention in general, but if you think about the clinical phenomena, so this is the work from Ismail on mild behavioral impairment. So he actually was not satisfied with the, you know, neuropsychiatric inventory as a predictor of earlier manifestation of behavior, right? So we know that neuropsychiatric inventory published by Jeffrey Cumming is a popular tool. We use it in all our trials. But Zainur, you know, was talking about, well, could we detect some of these changes in behavior? We used to call them personality changes. So he clustered them into different ways, like change in basically the mood component, when a person become apathetic, and most of us think that is this depression, or is it's a lack of motivation? Is that always depression? Well, it's not the case. Sometimes it's apathy, where the person actually, as you know, the trials have been done now to look at apathy as a target for treatment and successfully changing that. There's also changes in, you know, impulse control, as you know. Psychosis is a perfect example. Like somebody could develop hallucinations and delusions in the absence of any other syndrome, and we wonder, why is this happening in late life? It's not Parkinson and L-DOPA related. It's not cognitive disorder yet. It turns out that this could be one of those mild behavioral impairment changes that we can target. And this seemed to be predicting dementia, even, you know, like if you use machine learning, this is an example of how Zainur and group have looked at the possibility of detecting those changes. You can see that those behaviors, as you can see in blue, are predictors of converting to a cognitive disorder. Now, when it comes to depression, so if I'm a psychiatrist, a geriatric psychiatrist treating somebody with depression, we know that the risk of Alzheimer's disease and vascular dementia is quite high. So about 1.5 chance of developing Alzheimer if you have depression history, and almost 2.6 times for vascular. So it is a significant risk. So that kind of brings me to think about what else we can detect, right? So this is work that geriatricians did. I was mentioning earlier Manuel Montero Dasso, a colleague from Western who worked, and I think there's a paper in the 70s about walking and talking. It's a famous one where older adults, when they want to talk about something important, they have to stop and, so you can see they become conservative because they can't do it at the same time because now competition for resources happens. So you stop and say the important thing, then walk again. Otherwise, you may fall. But of course, we all know that walking around Charlottesville, in fact, this happened to me yesterday. I went for a walk, and 2 times a younger person was about to bump into me because they were just walking and texting at the same time. But they can do it because they have plenty of resources. And sometimes that, unfortunately, falls with age. So when I do that, climbing the stairs, I know I'm putting myself at risk of falls because my resources are shrinking with age. So this is the model that Montero Dasso have articulated. It's that like mobility and cognition are parallel. Like, so there's changes that you can detect in mobility that could actually indicate cognitive resiliency. So this is not a movement disorder thing. It's just really an aging thing. So you can actually see a change in mobility and cognition, and they do interact. So an older person have a slower gait. If they have mild cognitive impairment, their gait is even slower. And you can stress that by doing a dual task, right? When the person is actually walking and thinking, their gait now slows down further. And you can measure the, they call it the dual task cost, like how much serial 7 or counting backward or naming animal, how much that costs you. And you have a number. And that number is a predictor of further falls and further cognitive decline. Now, I put this here, as you know, gait could be thought about as something from the motor cortex down, but in reality, it's, there's an upper regulation of gait. So if you look at the image on the right side, it's really not just motor regulation. There's cognitive regulation and there's mood regulation that affect gait stability. So those are the things that we start seeing the overlap between these fields. So to give you an example, that in the motoric cognitive risk syndrome became a construct that people are using now to look at predicting cognitive. So the risk factor for cognitive impairment is that when you have somebody who is noticing a change in their gait and dual task even before developing a cognitive disorder. And in the Canadian context, the Canadian longitudinal study on aging, it starts at age 45. So one of my colleagues, Dr. Sekon, did actually a study to look at the motor cognitive risk syndrome prevalence and how much does it predict. So you can actually see that depression and anxiety have a higher rate of the syndrome, which translates to a higher risk of cognitive disorder, even from younger age group. In fact, the relationship gets lower as people get older, just because it becomes more likely that you're picking up cognitive disorder. But the risk, I think we should start earlier. That's the point. It's like motor cognitive risk syndrome can start earlier, and it's associated with depression and anxiety. We did a little study looking at late life depression and what's their dual task costs. So if you have people with cognitive disorders, such as mild cognitive impairment, they do have an impairment in their modulation of gait, so they actually have a clear cost of doing serial 7 and healthy controls on the other end. They don't have much of that cost. So people with late life depression seem to be in between. So probably some of them are destined to develop mild cognitive impairment. So, does that translate? Do we see any clinics today doing dual tasks for depression? I think that's a missing piece. I don't think, so we need psychiatrists and geriatric psychiatrists to be on board to say, if you have somebody with depression, you have to think about cognitive disorder, and maybe they don't have a failed MOCA today, but they could have subtle changes in their cognitive resiliency that you can detect through a dual task. So we actually articulated a triad in late life where we know that depression, late life depression, executive dysfunction, and slow gait seem to go together. We did a systematic review. There was about 11,000 participants for longitudinal studies. And we did see that 12 out of the 15 studies described that triad. So it's an example of detecting a change in cognitive resiliency in old age, where you can think about the possibility of mobility, cognition, and depression are integrated into this construct. And we think that this could be modified. Of course, we didn't see enough studies to show exercise, obviously, cognitive training could be part of it. So we need to think about started offering this as a wellness or cognitive resiliency. This is our triad in a chapter that we have published. And then some people have written about it. They think it's a good idea to look at the triad. So we're hoping that this will be one thing that we can chase. And then, of course, the question is like, what are we going to do about this? I actually did something quite early on. This is 2015 with Manuel Montero Dasso. We had a case that he referred to me who had multiple sclerosis, so it's completely out of my usual practice. But this person had a cognitive disorder. So he presented to the memory clinic, and they said, well, it's MS, and you have white matter hyperintensities. We don't know what to do. Like, if you are getting your treatment. So we did actually a trial of RTMS for that person, and we did see significant improvement in gait and dual task. And since then, I left that field, but it has been cited quite a bit. I mean, it was one of those trivial case studies that all of a sudden they at least cited 80 times. So it tells you that people are wondering about it, especially in the MS field. Like, could we actually use neuroplastic intervention like RTMS to rebuild some of those connections? Neuroplasticity has been shown with repetitive transcranial magnetic stimulation in depression. So this is work from Center of Addiction and Mental Health in Toronto by a Japanese fellow, actually, who looked at the EEG in this case and cognitive task. And you can see that treating depression not only improved the depression, it actually changes the neuroplastic markers where a person will have more efficient connectivity. They use actually the pair, a neuroplastic marker called the paired association task. They can actually identify the link between the click on the motor cortex and the median nerve and how long it takes for the pulse to travel. One of my very nice, smart students who actually just got to medical school now wanted to know the cognitive and gait effects of transcranial magnetic stimulation in those with old age depression. And it did show that, yes, there is signals in the literature that RTMS is something that we could use to enhance gait and cognition in late life depression. We're actually now doing a study that's going to do exactly that. We're using, RTMS is a field that have a lot of options. Like, you can do fast frequency, you can do slow frequency, but you can also do theta burst frequency, which neuroscientists would know that it's a very efficient way of actually modulating plasticity in the brain. So our study actually is something that will use continuous theta bursts on the right side, which tend to be inhibitory, and excitatory intermittent theta bursts on the left side. And this study is happening now. One of my fellows from the Philippines actually started this study, and now it's continued by a master's student. When we actually looked at the mild cognitive impairment group, we had 22 people in that previous study. Using high frequency did not do the trick. So now we're thinking maybe the efficiency of theta bursts will be more effective. So we'll see what happens. In general, cognitive disorders and TMS has been studied. This is a network meta-analysis showing that there are some robust signals. So left dorsolateral prefrontal cortex, fast frequency have a direct effect on memory, relatively good effect size of 0.88. There's also low frequency on the right side have been, which is, those who know the brain, there's always interaction between the left and right. So if you actually inhibit the right, you're exciting the left. So there's different way of doing it. It's a network framework. So you have to think about where you're going and what are you going to try to do. So there is definitely a signal that we're going to be following. There was a large study from Toronto that they looked at using transcranial direct current stimulation. So this is the milder electric stimulation of the brain with actually 9-volt battery, but it's positioned strategically on the prefrontal cortex on both sides. And they did that as a 5-year study. They had people who are late life depression, those with mild cognitive impairment, and then they followed them over time. It actually was interesting in this study that people with late life depression who were not depressed at the time of receiving this intervention benefited the most. So mild cognitive impairment did not benefit. So it just gives you an idea that maybe if there's a pathology underneath, like amyloid, it may not be as helpful for them. So we have to start thinking. So late life depression become a target by itself, like a major depressive disorder with mild cognitive changes. You treat the depression, they still have mild cognitive changes. This is an example of something that could actually make a difference. And it's a very non-invasive way of doing it. So TMS is a little bit more involved. It's not, I wouldn't call it invasive, but it's uncomfortable. You have to come to the clinic and you have, deal with the clicks on the head. But TDCS is very easy. This is work from Dr. Tariq Raji, who's now in Texas. He was in Toronto, and they call it the PACT-MD study. So getting back to where we're at in this journey. So we know now that the exercise intervention, this is a study that we are working on to try to modify mild cognitive impairment. So we bring people, this is the first study, people who have mild cognitive impairment, they can get into one of the 4 arms, they can receive exercise, cognitive training, and vitamin D. They can receive 2, so really stratifying them, and there's a control group that do not receive anything. So like they will receive what looks like an intervention, but it's not an active intervention. So this study is published in JAMA Open, and it shows that physical exercise, this is aerobic and resistance training, plus sequential cognitive training that's developed by Sylvie Belleville from McGill, actually has a robust effect size. It's almost a full effect size. It's got 3.9 on the ADAS-Cog. So it's actually quite good. So now we're actually, so this is the result of the synergistic trial. It does show that after 12 months, people seem to benefit from the exercise. The interesting news, I mean, geriatricians will agree, that vitamin D did not add value. In fact, we see a signal that may be bad news, like it may actually dampen the effect. We were not powered to say that statement, and it's going to be very provocative, and we're going to be hammered. But it's actually possible that vitamin D, if you have deficiency, that's different. But if you're giving it, we gave actually 10,000, so it's a high dose, it may not be good for you. Like it's one of those things that you have to think about, like what. So we actually thought about the moderating effect of that exercise. So ApoE status, as expected, it's indicated there's some underlying pathology. They did not do as well. So those are ApoE4 negative were better. And hearing ability, this is another thing. Those who had hearing impairment actually benefited differently. So males with hearing loss and lower baseline cognition benefited the most. So if you correct for these factors. So you can see that it's not one cut fits all. You have to think about resiliency in a different framework. We're now actually completing the bigger synergic trial with these exercises. So we have now 500 people already enrolled, and we have 50 more to go for one more year. This is when the person actually gets screened remotely. Everything happens from the comfort of their home. We have a coach working with them for a year, send them the exercises, send them the cognitive training that they do. And I think it's going to be a big, big news study, because we all know that the Pointer study from the Alzheimer's Society have shown positive effect. We think that this is a little bit more robust because it's guided and individualized and have coaching component, which is one of the limitations in other studies. In fact, the Pointer study, which was a lifestyle study, did show that people's compliance, adherence was a problem. So this is a little bit more of a coaching and supporting people to do the right thing. Now, talking about drugs, as you know, the pipeline for drugs is quite robust. We have Jeffrey Cummings, as you know, publishes every year the pipeline, and it's a busy pie, but I'll make it a bit closer to see that the disease-modifying biologics is now in the news. We know that we have donanemab and lecanemab FDA approved for, and it is approved in a lot of places. Lecanemab just got approved actually October 2025 in Canada. It's still not funded by any clear mechanism, so people have to pay for it, and it's almost like, I mean, in Canada, 32,000, so about 25,000 US first year, and then it cuts in half. We have, I mean, the states have been infusing people for longer, but we just started infusing people from October. One thing that I think people who are in the field know that lecanemab is not for everybody, so you have to have Alzheimer's disease proven by biological marker, like amyloid marker, mild cognitive impairment, early dementia maybe, but the signal weakens as we go with more impairment. ApoE4, 2 copies is higher risk of negative outcomes. So in Canada, they don't allow us to infuse people at homozygous ApoE4. In the States, I know some centers do. In general, people who have 2 copies of ApoE4 will have about 1/3 chance of having ARIA, which is the amyloid-related imaging finding, like the swelling. And the microhemorrhage is not much of a problem unless it's with the swelling, and then you have to deal with it differently. How effective it is, I mean, this debate is hot. I think the Cochrane group just published that it's not worth it. The problem is that I think it genuinely does something, because there is about 1/3 less likely, or 1/3 less decline by people about 10 months. But it's not the end of the story. We have to do much more work to refine our treatment. There's a lot of work on refining amyloid targeting to avoid the kind of inflammation. But at the same time, we all know that it's not just amyloid. There's a cascade of events. And so the later you start, the more damage already happened and the more cascade. So we have to get a little bit more proactive. Prevention studies are happening, and maybe that will give us something. But I think combining treatments and looking at cognitive resiliency as a concept, not just remove amyloid, how about building those networks? MRI monitoring is needed, as you know. That's another issue with access, especially in rural areas. It has to be given by infusion. This is the cost in Canada, and some of the coverage issues. Now, the last bit of my talk, I'm going to just go through it fast, is behavior. And we know that it's not only cognition and function, there's behavior, and the behavior continue to worsen with the disease. Agitation is one of the worst issues that defined as clear syndrome now at the American International Psychogeriatric Association. And it's bad news, because when people get agitated, they tend to exhaust their caregivers, exhaust the health system. It costs money, it causes a lot of negative outcomes. And it's prognostically bad. So those who have agitation progress faster and die more from Alzheimer's disease and dementia. So it's not a trivial problem. We have been, like the States, a lot of bad news about antipsychotics, and we were trying to find a solution for this. So we looked at prescription pattern long-term care. We were talking earlier about long-term care. A lot of nursing homes and long-term care want to bring prescription of antipsychotic to 0 if they can, right? So in Canada, we do have benchmarks to say it has to be below 10%, and people need solutions. So polypharmacy is continuing to be a problem. This is one of the studies we did with our databases. So one thing that we have started doing is that framework of called algorithmic management. We call it integrated care pathway, because we wanted to say if we agree on certain evidence-based practices, we want to make sure we enable that to be applied everywhere. So we had this study funded by Brain Canada and the CABI Center, and we published a couple things on it: how to design behavioral intervention, and also how to do the drugs. So this is the sequential drug algorithm that we now have been studying, which has different interventions based on evidence. I wouldn't go through the details, but in reality, we know what has evidence, and brexpiprazole now is the first FDA-approved drug for agitation and Alzheimer's disease. Risperidone, which is not approved in the States for that indication, is actually approved in Canada for that indication because it has, and in the UK. So we kind of classified, this publication is available if people want to look at it and use it. It's really about balancing between the speed of response, the quality of the evidence, and also tolerance of it. So we kind of did our best to articulate that in a framework that we studied. The other thing that we started doing is looking at measurement, because one of the problems with agitation is that you don't hear about it until it becomes a problem, until people get into the emergency room or get into trouble. So we're using some of the multimodal detection devices and AI to try to predict. And I didn't share all the details, but this publication tells you that we got to the point now where, this is only on the first 10 people that we analyzed, that we can predict agitation about 6 minutes before it happened in that sample. So we hope that more and more will be able to say to the person, you're getting agitated, or your family going to get agitated, or your loved one, maybe you should do something about it before it happens. We're doing some work in virtual reality for caregivers, because one of the resiliency questions is that, what are you going to do about caregivers? Like they're the ones who are exhausted, they're at high risk of developing dementia themselves from dealing with the stress. So we created something called the Virtual Reality Simulated Carer Program, which actually train people, and they can do it at home, obviously, or to actually deal with different scenarios. So we develop apathy, crisis response, refusal to care scenario, and we continue to add more. And we're now integrating something called self-authoring platform. So in a way, a caregiver can just record something to say, I'm dealing with the situation, and the AI tool will propose a specific theme, and we start creating that theme. So self-authoring platform will end up increasing the scenarios we can develop. And one thing I mentioned earlier, that integrated care pathway that we studied using the Brain Canada funding and CABI now is being extended to nursing homes. We have a plan to include 40 nursing homes to give them that framework, but also use technology, including wearable devices and VR tools to enhance that outcome. So this is, and part of the thing that's happening in the neuropsychiatry field is exploring, I know that Carol and I have suffered through the SCTAD, and it ended up being a failed trial, but now we're exploring cannabinoid and other agents like the AX05, which is dextromethorphan. So I wouldn't have time. I want to keep some time for question, but I mentioned the SCTAD trial, and these are some of the current studies, and some of them are already have shown the benefit. This is the cannabinoid studies that are actively in trial for agitation. The, I don't know if you're doing this trial here, Carol, but it's the CAR-XT. It's another mechanism, muscarinic mechanism. So in summary, research at the point of care is really add tremendous value to both the clinical realm and scientific realm, because scientists love samples. We love to answer questions. We think we have potential to adjust a lot of issues across the journey of cognitive aging and enhance mental and cognitive resiliency, but we need to be integrated into a framework that takes those into account. I love collaboration. I mean, I have a lot of collaborators from geriatric medicine, from neurology, from nursing, from science, and without doing that, really you lose the richness of this whole process of. And then networks of collaborators have been able to make a big difference in the field. A lot of people to acknowledge. Some of them are foundations, like the Slate Family Foundation is the one that gave us $6.5 million to study long-term care application of our model, but a lot of other agencies and funding. So I'd like to thank you. And this is my LinkedIn. If you want to scan it and connect with me, I know I'm connected to some of you, but welcome any of your questions now. I think we have a few more minutes. Thank you.
We have about another 10-15 minutes. Maybe we had a pleasure to having you answer your questions. You're speaking up. Okay, yeah.
Thanks for a great talk. I am really interested in the exercise intervention, and I'm wondering how you think about efficacy versus scalability and implementation. So I think we all could benefit from a personal coach to remind us to work out and all of that, but on a population level scale, how realistic is that? So how do you balance that?
Yeah, so maybe I don't know if there's other people online, I guess. So the question was really from the audience around the scalability of exercise interventions, given the fact that not everybody will have a coach. So, I mean, the scalability for me comes from really leveraging some of the technology that we have. Like, for example, one of my other colleagues is working on VR, and not just VR, by the way, like simulation through even two-dimensional screen, because not everybody tolerate the headset. So she has actually a Zumba class scalable solution that is, yeah. So those are, I think they're so feasible these days. I mean, they're intelligent, they can, what's nice about her study also, she picks up facial expressions and their reaction, vital signs changes. So one of her PhD student is finishing that study, and she also developing a digital twin to know that this is the person's profile before, during, and after the exercise. So it's really a nice way to capture and scale it, right? So I agree with you. I don't think we can hire a coach for everybody, but we don't need to. I mean, coaches are important to design and continue to monitor, but less of their time is needed because you can continue in between. And that's the same with psychotherapy, for example. AI tools now are applied in psychotherapy. It doesn't disconnect you from a therapist, but allow the person to work in between sessions with a trained AI model. It has to be done responsibly, though. Yeah.
Zumba. How to make cardiovascular smile? 3 components.
Question there?
Yeah, I think the most important lesson is for Alzheimer's is don't get it. So, what are the, if you could rank the top 3 preventive things that one could advise patients to do to not get it, what would be those 3 things?
Zumba.
Yeah, what?
3 things that don't require coordination.
Right. Less effort. Yeah. No, so the question about, what are the priorities in terms of 3 things you can recommend to people, yeah, so I think, one of the easy things to say, don't damage your brain. so really not drinking too much, not hitting your head, so anything that will harm your brain, try to avoid, not smoke. But then hearing impairment, like I said, a perfect example. How many people, I tell people, I'm wearing my hearing aid. My mom developed hearing problem in her early 50s. I have the same here. So I'm wearing my hearing aid. A lot of people still haven't tested their hearing. So, and this is one of the highest prevention ones. It's like the correct 7% of the, if you get depressed, get treated, right? So for me, engagement, so that's why, and then when you say Tai Chi, Zumba, it's really about social engagement and exercise. Instead of having it as regimented, I would say belong to a community that does this as part of their routine, right? So if you want to talk about something, go for a walk and talk about it, or participate in Tai Chi. So I think, hearing engagement would be 2 things, and don't damage your brain would be another thing.
So
Yeah.
exercise is below that.
Exercise is, but the level of exercise, by the way, this is important too, is like it's not required for you to do a lot of exercise. One of my collaborators from University of British Columbia measured it, and she said walking 4 blocks is adequate for actually cardiovascular and cognitive prevention. So we should be careful not to make people feel like, I want you to go from here to go to the gym and pump iron. What we're telling people is, get out of your home and do 4 blocks. If you can't do that, I remember this lady who said, well, I broke my hip, I can't walk anymore. And I told her, could you get those 2 pounds weight? And honestly, next time I went to see her, she showed me her muscles. She's like, look at this, So, we need to be a bit more permissive and flexible. There was a question there. Yeah.
So when you give this advice, like, you need to eat healthy, what does it mean to eat healthy? The same with exercise.
Yeah.
Exercise can have, you can exercise with intent and without intent.
Right.
Results are dramatically different. You can do small exercises with intent, you get very fit. You can do big exercise without intent, you get nothing.
Right.
So how do you control for that? How do you control in population?
Yeah.
Because it's very personal in a sense.
Right. So the question about, like, in a way, like dosing and specifics in terms of what do you recommend, how do you prescribe it, right? It's so the study that we're doing now, the Synergic 2, is it can actually be followed. We have now a grant to do a consensus on those exact measurement, like to say how much, for like the example that I gave earlier, walk rigorously for 4 blocks, for example, right? What do you tell people? If you have a watch and say if your heart rate went up to 110 for that duration, that's adequate. So we need to dose it, and we need to give people specific public health advice for sure. And our study actually will do that. The diet is another issue. So there's general rules. that are now accepted in terms of like the Mediterranean diet. Well, what's in it, right? There's the olive oil, there's the nuts, and there's the, not less red meat. But there are guidelines. I have seen some publication to say what you need is making sure you get this, this, and this, and don't do this, this, and this, right? But I think more and more benchmarking and metrics are important. I'm not an expert in the diet component, but I know for sure that I've heard some of the dietitians talk about the specific advice. The exercise one, I honestly think that publication by Teresa, I know her by first name, it's all about this. It's about what is the minimum that will be adequate, and you don't need to do more, because injury is another big problem, obviously, in the field. If you get people to get excited about exercise and they get injured, now you set them back even, So I start by saying, get a bit of a sweat. That means that your heart rate went above 100. Do it for, half an hour, you're done. Like, you don't need more than that, right? It's not, but as a scientist, you always say, what is the measure? What's the measure? I think it's much simpler than we sometimes think. Yeah, Carol? Then.
Thanks. Such a pleasure to have you here. It was great to talk with you this morning. I love your idea of the cognitive resiliency clinic. Do you mind just talking about what that would look like?
Yes. So I know, like over the years, resiliency was always in the psychological realm. I know, like some of the grants in psychological resiliency, that's a whole field, obviously, in terms of people getting out of traumas. And I think what I'm talking about here is really, providing your brain and health with the best possible chance. And as clinicians, the opportunities that I highlighted comes from being able to detect people when they have a change in their cognition, behavior, function, and create a pathway for them to know what is modifiable in that case, right? So people come to us from different risk point. So somebody who have a heavy risk of Alzheimer's disease, they're probably going to need more than a person who say, I don't have that history, but I just want to do well, right? So I feel like if we want to create a center of cognitive resiliency, you need to have multidisciplinary representation. Start with actually the dietitian, the exercise, kinesiologist, like people who are actually interested in providing that wellness lens, but have access to psychiatry, to neuropsychology, to geriatric medicine, because a person who have a bladder retention and end up on anticholinergic, gonna have a bad trajectory toward cognitive disorder. I can tell them that this is not a good idea, but I need some help to actually, so I feel like I'm interdisciplinary, interprofessional, start with wellness as a framework where all of us abide to, and have public engagement and public, health framework, but move into trajectory to assessment at least. Quick access to assessment so that a person will know where to, where's the emphasis, right? So, and hopefully with AI, we're gonna have a stratified risk index to say your cognitive index says that you probably can modify this and this and that, and you'll be better off, yeah. Yeah, sorry.
Thank you so much for coming out and doing this great talk. It was really, really cool. I appreciate it. And I was interested on kind of when you're talking about the progression of disease, starting early on with depression, almost as a prodromal sort of symptom. And I was thinking when you're talking about that, how many different things that, depression can kind of mean in different ways that it can present. So I was curious if there was any evidence or any thoughts that you had about, these people tend to be more, like melancholic with the poor sleep, the poor appetite, or, is there certain other features that tend to show up with that may pin that in your mind? So if you could comment on that, that would be awesome.
Yeah, thank you so much for the question. So this is about the profile that may alert you a little bit more to say, this is a bit of, I'm concerned about this person. They're not your average person with depression. So a study just got published, actually a Danish study that looked at that, and they have thousands of people, and that's a wellness study. And they did identify a profile of depression in mid and late life that is much more likely to progress to cognitive disorder. And the one that I shared earlier with Carol as well is that a person who's like flustered, so somebody would say, I used to handle all these things, like I'm a multitasker, this and that, and now I'm much more concerned about that person. So it presents itself in anxiety and depression. You treat it, but then that's the kind of person I want to bring back for a cognitive assessment to see what happened to that. Because a very old study, in fact, from Columbia, showed that the residual cognitive impairment in late life, so 40%, so those who recover from depression and have residual cognitive impairment, 40% of them progress to mild cognitive impairment of dementia, right? So in a way, without that integrated model, we're not going to be able to say, it's not done. Your depression is done, but I still see that you have cognitive issues. So where do I send you now, right? Prevention study, maybe you're the amyloid positive person that could benefit from infusion. Maybe you're the person who's developing Parkinson. I haven't talked about Parkinson today, despite the chair being a Parkinson specialist, but I've done years of work with Parkinson disease, anxiety, depression, psychosis, and the same thing showed up there. Like, a person is not done by treating the depression. There's something evolving, and cognitive disorder in Parkinson can present itself with anxiety sometimes, and so I really love integration, because for me, that's the only way for us all to enjoy our work and know that we're not just dumping the person at the end of our journey. They have a longer journey to go, and then we need to be with them and with their families.
This is lovely. Thank you so much.
Appreciate it.
I enjoyed it. I enjoyed it very, very much.